And then you just advance the.
Yeah. This one is just use that one only.
¿Es the camera good?
It should be.
Se ve bien.
Hey, good morning. Good morning, everyone. Good morning and welcome to the new members of the team here. Look forward to meeting you individually later on today or during the week. So today we start our new season for cardiology grand rounds, and certainly we're going to start really with a bang. It's a great pleasure for me to introduce Dr. Nathan Wong. Dr. Wong is a professor and director of the Heart Disease Prevention Program at the University of California. He's co-director of the UC Irvine Center for Global Cardiometabolic Health and Nutrition, and a fellow with the American College of Cardiology, American Heart Association, the National Lipid Association, and a master of the American Society of Preventive Cardiology. He's a current co-chair of the California ACC Prevention of Cardiovascular Disease Committee. His research interests include cardiovascular risk assessment and subclinical atherosclerosis. He did pioneering work in coronary calcium and in the epidemiology and management of dyslipidemia, diabetes, and obesity. He has been investigator in some of the most important trials in cardiovascular prevention, including the Framingham Heart Study, the MESA study, and the Women's Health Initiative. He has authored over 450 peer-reviewed manuscripts, 8 textbooks, and the companion to the Brownwell heart disease book, the Preventive Cardiology Companion. So it's a great pleasure to have him today, and he will speak today about coronary calcium and the role in preventive cardiology. Wong.
Well, thank you very much, Dr. Garcia. And first, I want to welcome all the first-year fellows. So welcome to Montefiore. And maybe one of these days, some of you might end up in California. So anyway, yeah, so I am a cardiovascular epidemiologist by training and have had a long standing interest in actually preventive cardiology. And one of the areas that I got involved in pretty much at the beginning of my career was looking at coronary calcium as a risk assessment tool. And we've come a long way since then. So I'm going to kind of walk you through a little bit of the actually history and some of the early work we're doing, and really mainly focus on how it is used in preventive cardiology and assessing patients who perhaps should be best on preventive treatment. These are some disclosures. So we kind of start with this, and this is, it's wonderful to talk about this for your first lecture for the first year fellows is because, the foundation of cardiology is really risk assessment, right? We have to know our patient's risk because that determines how intensively they should be treated. So Dr. Bill Cano is pictured here. He was one of the most probably the most famous director of the Framingham Heart Study for many, many years. And he was my mentor at Yale when I was doing my PhD work there. So he published this report, ironically, the year that I was born, where the term risk factors was coined, right? This is a topic that is used in just about every area of medicine. And he really showed how the burden for the first time, right? The burden of risk factors, in this case, he only had elevated cholesterol, LVH, as well as elevated blood pressure to work with. But he showed that the more the number of risk factors, right, the greater your risk. So this is really kind of the beginning of what we call actually global risk assessment. And so as I mentioned, preventive cardiology really begins with assessing your patient's risk. This was in American Society of Preventive Cardiology clinical practice statement that I chaired a few years ago. So we kind of walk through the different steps of cardiovascular risk assessment. And we usually begin, right, with a risk score. So there are several used around the world. The Framingham Heart Study had the first risk scores going back to the early 1990s, developed by Peter Wilson, who I know well as others. But as you know, in 2013, our pooled cohort equations were used, and these are implemented in the actually EPIC and perhaps other EHR systems as well, right? And they estimate a person's 10-year risk of a hard atherosclerotic cardiovascular disease event for people 40 to 79 and lifetime risk for people 20 to 59. And remember, these are used in primary prevention. They're not appropriate for people with pre-existing ASCVD. There are other risk scores used in secondary prevention that we won't talk about today. And they're also probably not appropriate for people with familial hypercholesterolemia, right, who have had a lifetime of risk. And they're really intended to promote that patient-clinician risk discussion. So we use this as a starting point in assessment of risk. But more recently, in November of 2023, the prevent risk scores were released as part of this new CKM, as they call it, right? Cardio kidney metabolic syndrome concept that has been promoted by the American Heart Association, really recognizing that close association between cardiovascular, kidney, and actually metabolic conditions. So here you can see the various inputs. They actually took race and ethnicity out of the equation because it is felt that that may end up perhaps over or under treating certain groups simply because of the color of their skin, but instead there's a social determinant of health you can enter in your zip code, right? So like my risk is 8% by including the factors in the base model. They also added in BMI and EGFR. But because I live by the beach in California, where the air is nice and fresh, I put in my zip code and it comes down to 4.9%. Okay, so that can be useful. But we know that these traditional risk assessment approaches have really limited accuracy, right? Many people who develop coronary disease events have rather few risk factors, as shown in the pie chart. And we know that when we try to look at who actually gets events, some of the risk scores, particularly the PCE, which was based on older cohorts that had a higher risk. It's less of a problem now with the prevent risk scores, but the PCE tends to overestimate risk. So we have to think of strategies that can improve our ability to refine risk, right? And in our 2013 guidelines, or I should say 2018 guidelines, the actually cholesterol management guidelines, it was recommended that we assess this list of risk enhancing factors. So you should always have this information on hand that can further inform the treatment decision beyond the person's 10-year risk, right? So you should always know which first-degree relatives were affected with premature ASCVD. So it's not a simple yes, no, as I always say, but it's the number of first-degree relatives, and it's how young were they affected, right? And then persistently elevated LDL, metabolic syndrome, CKD, chronic inflammatory conditions. Always do a complete reproductive history of your female patients. Factors such as gestational diabetes, preeclampsia, low birth weight infant. These can also increase risk, premature menopause as well. Certain high-risk race and ethnic groups, such as South Asian individuals or African American individuals, and then certain lipid biomarkers. I've been doing a lot of work with lipoprotein little a recently. There's some very exciting trials in progress now, which we'll see if they end up being positive. And there's also been interest with polygenic risk scoring, right? And there's some data, including some I've done in collaboration with the Kaiser Permanente group in Northern California, that show that you get added risk prediction from adding a 12 SNP polygenic risk score on top of standard risk factors. But over the years, there's been really a search and a consideration that we should actually be measuring the disease process. So this whole concept of measuring subclinical disease that I've been very interested in over the years, and getting involved in MESA. You know, we've looked at not just coronary calcium, but abdominal aortic calcification, ankle brachial index, carotid IMT and carotid plaque. There's also measures of microvascular reactivity involving fingertip tonometry that has less evidence, but certainly can be a way to assess microvascular disease. And on the carotid ultrasound, certainly we know that so it was actually taken out of the US guidelines, this carotid IMT alone, but the combination of carotid IMT and plaque is considered an alternative that can be used if calcium scoring is not available in the European guidelines. We'll see what happens if this is reintroduced back into our US guidelines when they get revised as early as next year, I understand. With ankle brachial index, you're seeing pretty good reclassification of risk, particularly in women, right? Almost 40% get reclassified. And this basically shows you here that you can have, you know, that if you're in the borderline range, right? So remember, ABI of less than 0.9 is diagnostic of peripheral arterial disease. But if you're in the borderline range, you also have about nearly a twofold greater risk of mortality. So this is included as one of those risk enhancing factors in our guidelines. But the focus of today is really on coronary calcium, right? So this invariably indicates the presence of atherosclerosis, but we know that not all lesions are necessarily calcified, and it can occur fairly early in life. It's not necessarily just a late stage phenomena. We've seen, for example, adolescents with familial hypercholesterolemia to have coronary calcium. It really does correlate with plaque burden, right? And it's highly sensitive for angiographic disease. So if you have significant angiographic disease, you're at least going to have some coronary calcium, right? So it's kind of the tip of the iceberg concept, right? And the more that is showing above the water, right, the calcified plaque in general, the more total atherosclerotic burden you have. But this relationship is highly variable. So we have to remember that, you know, some people may have very little or no calcium, but still have non-calcified vulnerable plaque. You know, that's possible, but in general, you still have, you know, you do have a pretty strong relationship. The radiation is pretty minimal, right? It's about that of a mammogram. So this is frequently thought of as the mammogram of the heart, much less than coronary angiograms or nuclear imaging. And remember that this was kind of the seminal paper in 1990 that Arthur Agatston wrote and really defined that Agatston score, right? So this was based on a product of the actually calcified area and a density score that was based on the maximum Hounsfield units and given an ordinal ranking of 1 to 4. And at that time, they noted that, you know, it may have prognostic significance, but that hadn't yet been determined, and future studies are needed. So I'm actually, Bob DeTrano and I had the first NIH R01 that looked at the prognostic significance of coronary calcium. And initially, because we did not have a electron beam CT that were the first CT scanners that were used to quantitate calcification. We used cardiac cinephorescopy, and you can show how the prevalence of coronary calcium increased by age, and that it was an independent predictor of having a coronary heart disease event within 1 year, as shown in the table on the lower right. And then I did some other epidemiologic studies in the early 1990s. I was involved with, we showed in the South Bay Heart Watch for the first time that African American individuals had much less calcification than actually other ethnic groups, you know, perhaps supporting the concept that much of what they have is hypertensive heart disease rather than atherosclerotic cardiovascular disease. And then, you know, we looked at how the number of risk factors was directly related to the amount of coronary calcium, and how specific risk factors were independently associated. If you were a woman, you had much less calcification. Hypertension, hypercholesterolemia were associated with a higher likelihood, as well as increased age, right? So ranging from 15% in men under 40 to 93% over 70. In women, that was 30% to 75%. And then in this very early review article that I wrote, you know, we pointed out that, you know, active research and emergent findings may soon make it possible to recommend whether certain subgroups might benefit from calcium scanning. And then we had one of the early, although very small, outcome studies looking at a screened population in the Orange County area where I'm from. And you know, you can see the higher the calcium score, the higher the risk. Of course, this was the beginning, and the key seminal paper came from MESA, right? The multi-ethnic study of atherosclerosis that really was the first, you know, multi-center NIH study to evaluate, really designed around evaluating the importance of coronary calcium. In fact, it was originally, before it actually was given the name MESA, it was called a subclinical cardiovascular disease study, but then they renamed it MESA. But in the grant application, it was considered that. So you can see here, of course, the higher the calcium score is, the higher the incidence of coronary events. But what was important about this paper was that it showed that you got similar prediction in the four major ethnic groups that MESA looked at, right? That included white, African American, Black, as well as Chinese were included. Now, there was also a study that was based on the MESA protocol designed that came about 10 years later called a Masala study in South Asian individuals. And this really nicely points out how the trajectory of increased age and higher calcium scores is, while steepest in white individuals, is next steepest in South Asian individuals. And this is certainly consistent with their premature coronary disease. And actually, I'm very active as one of the 2 international advisors for the Lipid Association of India. And we promote in our highest risk patients with ASCVD, our recommendations are to have the LDL cholesterol down below 30 milligram per deciliter, and even lower if people continue to get recurrent events. So the concept being that the other international guidelines are really not appropriate for South Asian individuals because they are getting coronary disease 10 years earlier on average, despite similar LDL cholesterol levels. So we have to be more aggressive. And that's what our Lipid Association of India promotes. And then in the 10-year follow-up of MESA, what you can see here is that the main take-home lesson is that people who have calcium scores of greater than 100, regardless of whether you're white, Chinese, Black, or Hispanic, these individuals have a more than a 7.5% 10-year risk of ASCVD, which is that level at which there's net clinical benefit from statin use. So the main message here is that if your calcium score is greater than 100, this is where where the benefit is in favor of taking a statin. What about the power of 0? This is an interesting concept, right? If you have 0 calcium, what does that mean? Well, we know that it is the single best predictor of not dying, right? So the bottom line shows the mortality rate over 15 years in people with a 0 calcium score. That is lower than if you have a Framingham risk of less than 10%, or you have no risk factors, or you have a ATP3. This is a fairly old paper, so they use these older scores of less than 10%. So there's no other tests that can better de-risk somebody than a coronary calcium scan. And there's also data from other studies that show that CAC0 is associated with a low prevalence of non-calcified atherosclerosis, right? So so it's still, you know, you may have some non-calcified atherosclerosis, but it's quite low in prevalence. What about progression of coronary calcium, right? And while you know, the only recommendations that we do have is from the 2018 guidelines that note that you could consider rescanning people basically after 5 years to see whether their disease has progressed and if you should be more aggressive with treatment. And perhaps this individual might get rescanned if he hasn't already. Maybe he should pay more attention to his coronary calcium than trying to cut our budgets. So that's a commentary, okay? Not meant to reflect the opinion of Montefiore. That's okay. So okay. Yeah, so this is a paper that Matt Budoff and I, you know, and others wrote, and so we show that, you know, incidence of coronary heart disease is greater, the more rapidly your calcium progresses, right? Because remember, MESA had serial coronary calcium scans. They've had up to 4 scans. And I will say that these prospective studies such as MESA, Cardia, and others, they're an amazing resource where numerous cardiology fellows like yourselves and medical residents have really made a career out of publishing from this. And in fact, this paper here, a former cardiology fellow of ours, Shaista Malik, who's now our Associate Vice Chancellor for Integrative Health. She's a preventive cardiologist with us at UCI. But in this paper, we showed a tenfold variation in coronary heart disease event rates in people with diabetes or metabolic syndrome, depending on the amount of calcium, right? So the message here is that, diabetes is not necessarily a coronary heart disease risk equivalent, but the risk really depends on many factors, right? Duration of diabetes, severity, as well as coronary calcium. So there's been some guidelines that kind of vacillate back and forth about whether they should be, that whether calcium scoring should be used in people with diabetes to stratify risk. I strongly believe it should. We also have this paper from a few years ago that showed that a calcium score of greater than 100 was a stronger predictor of cardiovascular and total mortality in women compared than in men with diabetes. So you can see these higher bars for women for calcium scores of greater than 100 compared to men. And in the interaction term was statistically significant in multivariable analysis. Now, this paper by Yaboa more than 10 years ago pitted the calcium score against other tests, right? And really showed that the C statistic was by far improved more from adding calcium to the Framingham risk score compared to these other measures like carotid IMT, full-mediated dilatation, ABI, family history, or CRP. So it really helps support, the statement that we, as well as others, have pointed out in other scientific statements, that a calcium score is probably the most useful of our subclinical screening tests because it provides substantial improvement in risk reclassification, including those people with diabetes. Now, what are the benefits of having a calcium scan? So in this study that I published 29 years ago, we showed how in a not too large of a sample, only about 700 people, right? How if you had a calcium scan and a greater the score, patients were more likely, this was just a simple survey that we did, they were more likely to report that they started aspirin use, cholesterol lowering medicine, see their doctor, lose weight, decrease in dietary fat. It also made them worry a little bit more, but whether that's a good thing, hard to say. But at least it gets them to see their doctor, right? And then in the Eisner study done in collaboration with actually Dan Berman at Cedars-Sinai, who headed the study, and others, including Leslie Shaw from here in New York, was involved in it. So we showed here that if you were scanned, so people were randomized 2-to-1 to scanning versus no scanning. And the people that were scanned did not have an increase in their Framingham risk score, whereas the people that were not scanned, you continued to show an increase. So the scan tended to motivate, and the higher the calcium score, it tended to motivate better treatment. So the LDL was reduced more, the blood pressure, people exercised, people took a range of preventive medicines that were more likely to do that if they had higher calcium scores. But What we still don't have is whether hard clinical endpoints are actually benefited from coronary calcium scanning in a large asymptomatic population. So the Dan Canvas trial took an attempt to do this. Now, what was interesting and perhaps a significant limitation, as you can imagine, they only studied men 65 to 74, although a very large number of them. And they included a range of screening tests. So they did get calcium scoring, but they also got ABI and they got blood samples to measure sugar and as well as cholesterol levels. And their main outcome was all-cause mortality, right? So some of us asked, well, why wasn't it the composite MACE event, MACE composite that we usually use, right? Which is MI or stroke or cardiovascular death. And then they had, of course, secondary outcomes. So at the end of the day, it did not quite reach significance for total mortality. But if you looked at the men under 70, there was a statistically significant 11% risk reduction. They later published another paper last year in 2024, where, and this is kind of a strange thing, but they reported on what they called user-defined outcomes. So the subjects defined what was most important to them, and the user-defined outcome of MI and stroke was significantly reduced, 7%, not much more than the primary study, and the composite MACE 6%, and these were statistically significant. But this study, I think, as most of you would agree, is probably somewhat inconclusive. It has a very limited population, just looking at men 65 to 74, that would be frowned upon, at least here in the United States. So we're anxiously awaiting the Robinska trial, right? So this has randomized about 40,000 people from the Netherlands, and they randomized them to the European score algorithm, coronary calcium screening or no screening, and the people with an increased score or get cardiovascular risk factor modification, and then they'll look at outcomes. So that's supposed to come out shortly, right? Okay, so different in possibly sometime this year, I heard. So so different indications for calcium testing, right? Intermediate risk patients, a statin reluctant intolerant people, and it can really help identify people who may be most likely to benefit from statin as well as other preventive therapies. We do have something called a MESA risk score, which you can look up and you can enter in your numbers and your calcium score. And in this representative patient, 58-year-old male, white male, without diabetes, with a family history, total cholesterol 190, HDL 40, systolic blood pressure 126. So without information on coronary calcium, the person's risk would be 3.1. But this person, if we gave him a calcium score of 276, that increases to 13.7%. So you can see how this can inform the treatment decision. We know that from MESA and other studies that if you have a calcium score that's at least 100, you can see how the statin users in red have much lower event rates. So it does appear, this is not a randomized trial, but observational study, it does appear that the statin users derive significant benefit if your calcium score is greater than 100. But if it's less than 100, the lines are basically superimposable. So some people really feel that maybe we can withhold a statin when people have little or no calcium. But a number needed to treat for a calcium score of greater than 12, of greater than 100 of 12 is very, very favorable, right? And then there's also been discussion by others that we can help identify those that are, maybe are most likely to benefit from these expensive therapies, like to treat high-risk people with familial hypercholesterolemia. With limited resources, we can identify those most likely to benefit. Certainly aspirin also, right? So if you have a high calcium score, you see the number needed to treat is very favorable for aspirin use. If it's intermediate calcium, you have to have a 10-year risk of greater than 10%. And more recently, Alex Razavi, who's a cardiology research fellow at Emory, he's really published an enormous amount of very fine work in this area, showed that applying the select eligibility criteria, right? Remember, that's the trial for actually semaglutide, the GLP-1 receptor agonist, that showed cardiovascular risk reduction. And so he showed basically that your calcium score had to be 300 or greater in these asymptomatic MESA people in order to likely derive benefit from this weight loss anti-diabetes therapy called semaglutide. So our guidelines point out that if you, once you go through the 10-year risk estimation, the consideration of risk enhancing factors, if the treatment decision is still uncertain, then you can consider coronary calcium. A 0 calcium score, you're below the threshold for treatment. You could consider postponing or delaying or withholding therapy unless you have diabetes, heavy cigarette smoker, or strong family history. If you're 100 or higher, you should definitely be on statin therapy or greater than 75th percentile. I was recently involved in this this statement where led by David Marin, where we propose staging disease. So staging atherosclerosis according to the amount of calcification. The idea being that if you stage disease, like with heart failure, it's more likely to be actionable. And here you can see successively lower LDL targets with recommendations for statin and non-statin treatment. So if you're 300 or higher, we want to see that LDL below 55. And this was really based on, but we took it one step further. It was based on not just the 2018 cholesterol guidelines, but the 2022 ACC expert consensus decision pathway. But we took that one step further based on more recent recommendations for the very high risk individuals to be below 55, and I understand from Dr. Slipczyk that you have implemented this here at Montefiore. So I want to congratulate you for really taking a proactive approach to getting your patients better treated. Matt Budow's paper from the Confirm registry recently showed that a CAC score greater than 300 really equates to secondary prevention. So these individuals, you could definitely justify probably secondary prevention therapies. And of course, I noted that if you have diabetes and a calcium score of greater than 100, you're also probably at that risk. And then, so many, and I'm just showing this just to point out that there's interest in, really recruiting patients with calcified atherosclerosis who are most likely to benefit from newer therapies and randomized clinical trials. So moving forward, and even there's some trials now ongoing that are using a high calcium score as an entry criterion. Okay, so I know we're running out of time. So the last few minutes is just to mention about opportunistic screening. So there's, as we know, not everybody has access to or can get a coronary calcium scan. There are far more people that are getting non-contrast chest CT scans for other reasons, such as lung cancer screening. Unfortunately, CAC is inconsistently reported from traditional radiologist reports. SCCT and other societies do recommend report and CAC on all non-contrast CT scans. You can see here, like 19 million people are getting CT chest scans, but only about 1 million coronary calcium scans. Yet there's a pretty good correlation between the amount of calcium you get from a gated and a non-gated CT scan using software. We also have new AI software. Several algorithms are now available that can pretty accurately detect the amount of calcification. In this case here, a deep learning algorithm shows that the amount of calcification definitely predicted all-cause mortality and cardiovascular events. A very recent one published by my colleague at the Long Beach VA and others around the country applied this to the VA healthcare system and also shows a higher risk of all-cause and cardiovascular mortality in people with higher calcium scores. David Marin's study showed that if you randomize people to being notified, them and their physicians to be notified or not about coronary calcium, that the people that were notified were much more likely, 51% compared to 7%, to be prescribed statins at 6 months. So this can really, I think, revolutionize our ability to detect many people and treat them to reduce their cardiovascular risk who would not otherwise be identified without such a process. So the hope is to, try to really implement, assessment of coronary calcium from non-gated scans at our institutions. There are many women, for example, who would have no idea about their cardiovascular risk unless they're identified. And there's other AI technologies that can look at plaque characterization, for example. And in this paper, I was recently involved with the people at Heart Lung. We showed that AI plaque characterization did improve risk prediction beyond the traditional Agatston score over 15 years from the MESA data. Also, there's a lot more that you can look at from the CT scan, and I'm just going to touch on a couple of these briefly before we close. You can, in cardiac chamber volumes, other calcification, including aortic valve calcification, bone density, liver fat, muscle fat. These are some of the components. And so there's tremendous opportunity. Here, we're able to show that the higher the calcium score, the more likely you have increased LA sizes or LV sizes. Even people with zero calcium score, a fair number of them have an enlarged left atrium or left ventricle. And this seems to predict heart failure even better than NT-proBNP, as we've seen from the MESA study. And the case examples are people who have enlarged chambers despite having a zero calcium score. Okay, so a zero calcium score does not guarantee that you're not likely to have other adverse characteristics that could affect your probability of developing heart failure, or in this case, some atrial fibrillation. The RMAI technique improved over the CHARGE AF risk score, as well as BNP, increasing that area under the curve, and also predicted outcomes similarly to MRI, right, which is a gold standard for looking at these cardiac volumes. And then lastly, here we see liver attenuation index. So So the idea is that we can look at liver steatosis from a CT scan, and you can see that the liver attenuation index here directly relates to the likelihood of cardiovascular events. So this is a hot area of investigation. And the last thing is trying to leverage the mammograms, right? So there's a lot of interest in being able to detect incidental breast arterial calcification from the mammograms, and there's AI techniques now available to do this. This study I was involved in did not use AI, but it did show that 26% of women had evidence of back, and that was associated with about a 50% greater risk. So the idea is that if we can identify back, it can help motivate women and their physicians to further assess their cardiovascular risk and possibly to consider preventive therapies if further verified. And the UC San Diego group has used a AI generated breast arterial calcification algorithm. And here they also show a 50% greater risk of cardiovascular outcomes in people with back. So what the authors conclude is that this can improve personal risk stratification, providing patients and clinicians with evidence for shared decision making, and it should at least at a minimum stimulate patient-provider risk discussions on lifestyle changes, particularly among younger women. So I think with that, we've discussed how we start with global risk assessment. We consider various risk enhancing factors, and then in selected patients, certainly imaging, and particularly now with the wealth of evidence from coronary calcium scanning that has accumulated over the last 35 years, really kind of places this at prime time to really help better assess our patients' risk. And now we have, of course, AI techniques that can even go beyond assessment of calcium, can look at non-gated scans, can look at other things such as cardiac chambers that can predict risk of heart failure and stroke. So a lot of excitement in the field now, and I think it's a real opportunity for us to better step up prevention and how use of these imaging techniques can help guide that. So we've talked about many of these things, CAC and its motivation for preventive behaviors and how it can inform the appropriateness of preventive therapies and of course the AI technology. So sorry, went a little over, but thank you for your attention. Yeah.
Thank you very much. That was a really wonderful lecture. We will go now to the Q&A. So if you have any questions, you can enter them in the chat. And I'll start with one question, or maybe Dr. Garcia has the first question. Go ahead.
Yeah, actually, I had a couple of questions. The first one is the comparison between the different prediction tools. So starting from priming and to the current time, there have been 30 years of evolution. So adoption of a statin therapy has changed. Diets have changed in the society. And now we have TikTok. So we don't know the effect or the prediction changing over time. Do we have to revise the performance of one tool after a certain amount of time to see if the prediction ability is still valid?
Yeah, okay. So I think the question, to summarize it, if I understand it correctly, is, you know, is whether the odor scores, you know, whether we need to revalidate them because they were based on older populations and how that impacts our preventive treatments. You know, so I think my kind of take on that is that, these older scores were limited in terms of factors that they looked at, like the initial Framingham scores. They also just predicted coronary heart disease, right? So the initial scores only predicted coronary heart disease, but in 2013, this was expanded to ASCVD, and now with the prevent risk scores, you're predicting total CVD because we're more concerned about more than just coronary heart disease, right? We also care about stroke. We care about heart failure, right? So the scores are all different in that respect. You have to look at the endpoint. You have to look at the time duration. The development of the newer ones, such as Prevent, have been validated in very large samples. So the validation has been more rigorous than, say, when the Framingham scores were first developed, we didn't really have a validation cohort because that was all there was. There was only Framingham back in the late 80s and early 90s. And we know that these constantly have to, if you're going to apply them to different populations, they have to be recalibrated for those populations. So the European scores actually have the calibration factor to adjust the baseline risk depending on which country it's being used. And that's not something that's done, and some have argued maybe that should be done in the US because we have as much heterogeneity across our 50 states than Europe may have across all their countries. So I'm not sure if that completely answers your question, but I tried my best.
If I can have one more. So my hypothetical 30-year-old man comes to get a calcium score because he's worried about the chance of him developing a cardiovascular event in the future. While he's in the scanner, he said, well, why don't you put an IV and inject some contrast and evaluate me also for non-calcified plaque, because I've read that non-calcified plaque is more dangerous. Do you ever consider CT coronary angiography as a screening tool?
Yeah, well, I'll take a stab at this, but certainly Dr. Slipczyk is our expert here on CTA, so you can comment too. But there are certain populations where, a CTA might be recommended in an asymptomatic person by some guidelines, but and you know much more about the CTA recommendations than I do, but such as people with diabetes, people with a strong premature family history. But we have to remember that we have data such as from the multi-center confirm registry done around the world and other registries too that really show that in most asymptomatic people, the calcium score, or I should say that the CTA information does not significantly improve risk prediction beyond the calcium score itself. So, I think in most people, the calcium score, is enough, but maybe you have some comments about that as well.
No, I agree. I think the value comes from what you showed. I think with showing high-risk plaque features and AI, stratification of non-calcified plaque will bring us the additional value. The question is always if you're measuring noise, and you have to be very careful with young people not to give them a diagnosis they don't have if you're measuring noise. So I'll ask one question. I know you're very interested in lipoprotein A as well. What are your thoughts on people that have high lipoprotein A but calcium score of 0? Should we treat them with statins? Should we treat them with aspirin?
Yeah, so it's interesting because we're actually working on a paper on that right now, but I think what some of the data so far seems to suggest, like with other risk factors such as LDL cholesterol or even the number of risk factors, that if you have a calcium score of 0, your number needed to treat is going to be much, much higher, whichever therapy you use, whether it be a statin or one of these newer LP-little-a lowering agents coming out. And, I think it's going to be likely that, we don't have the data yet, but I will bet you that if your calcium score is 0, and unless your LP-little-a is extremely high, you may not derive much benefit from treatment, but I think, we have to be careful, of course, because, the calcium score is, looking at calcified plaque. It's not looking at all plaque. And some people with very high elevated LP-little-a may still be at significant risk, even if they have a 0 calcium score.
Thank you very much. We have a question from Felipe here in the audience.
The question was very similar to the one that Dr. Garcia did. That I mentioned that in your talk, you were talking about particular groups that are very high risk, that's patients with severe hyperlipidemia, and the famous power of 0. So I was thinking about the use of coronary CT angiography as preventive measure for evaluation of non-calcified plaque, due to the fact that non-calcified plaque can also have very recent futures to predict a major cardiovascular event, that because that is a semi-quantitative analysis, if the evaluation of pericoronary artery adipose tissue quantification or epicardial adipose tissue quantification could play a role in these very high-risk patients with the famous power of 0.
Absolutely, yeah. I think there certainly may be a role in select high-risk populations, and other features like pericardial fat, as you mentioned, can play a role. I'm curious what your practice is in terms of specific patients that you might recommend going directly to CTA.
Well, I think this changes a lot, and here the guidelines are not supporting it as much. I think, we don't have enough recommendation to do it in asymptomatic patients, and there's no coverage. So for us, it's very hard. However, there's a lot of patients that we get a CT for chest pain. That is the first indication to do CTA, and we find non-obstructive coronary disease. And then how to re-stratify these patients and treat them accordingly, I think is a low-hanging fruit for us. Hopefully I answer your question, but I think more data is coming. We have multiple ongoing trials in asymptomatic people with CCTA. So we have a question from Carlos Rodriguez. Nathan, great lecture at Tour de Force. Any studies or any thoughts of using CAC after a negative stress test to further re-stratify patients with non-epicardial CAD-related chest pain?
Okay, well, that's a mouthful of a question, and I'll ask you to comment on that too. Well, I think one thing that we have to realize, and this is the whole rationale for a CAC testing, right? It's an anatomical test, and so there are many people with negative stress tests, right? Remember, to have a positive stress test, you really have to have significant stenosis, and that may or may not be present. You could have, significant CAC without significant stenosis. So these are, these are complementary. And I think in people at, the recommended risk levels, at least, regardless of whether they have a negative stress test, they would this as well be candidates for calcium testing. Maybe you have an opinion.
Yeah, I think it's very different. I think it's a great question. It's very different. The question is this chest pain coming from epicardial significant stenosis? And the second question is, does my patient have coronary atherosclerosis? And I think the calcium score will answer the second question, that is as important, if not more, of the first one. We have a question from Dr. Lorenzati. Thank you for that amazing overview. What do you think of aspirin in primary prevention? Do you have good data to support the use of CAC to guide aspirin therapy? Which threshold, 100, 300, any percentiles that we use?
Yeah, so Yeah, so first of all, remember that our guidelines regarding aspirin use have actually become more conservative because recent trials such as Ascend showed absolutely no benefit, even in people with diabetes, where the risk largely counterbalanced the benefits. In terms of CAC, I showed a slide very fast that showed the data from a Medema from the MESA study where the number needed to treat was favorable if your calcium score was greater than 100 or if it was 1 to 99 and you had 10% or greater 10-year risk. That's where you seem to have net clinical benefit from aspirin use. So, it's kind of a combination of risk factors and the amount of calcification, but I think in general, we would say someone with a calcium score of greater than 100, the benefits would outweigh the risk from aspirin therapy.
Thank you very much. We have a question from one of our new fellows.
All right, hi, morning. So I had a quick question. So I remember you were saying that for specifically the African American subgroup, that for them, that they have less calcium in general, it's mostly like hypertensive related disease. So how good is a score of 0 in like negative prediction for them as a subgroup?
Yeah, so that's a very good question. So, as I showed in MESA, from the 2018 publication, right, that the, prediction is with a given calcium score, for events is similar, and this was shown in the earlier MESA paper too. It's similar across the different race and ethnic groups. So a calcium score of 0 would, relate to a low likelihood of at least ASCVD events, right? But remember that hypertension and other risk factors, even LP(a) is much higher in the African American population than in other groups. So, you can't just rely on the calcium score. I think the calcium score is very valuable for everyone, but we always have to look at these other risk enhancing factors, and they may differ in terms of their prevalence among certain race and ethnic groups. We know South Asians have a lot of metabolic syndrome and visceral fat, even at normal BMI levels. And you see kind of, a more muscular appearance in African American individuals, right? And African American, particularly African American men, have the highest HDL cholesterol levels. So that can help maybe protect against ASCVD. So we have to, we can't just rely on the calcium score, but you have to look at the comprehensive risk factor profile to individualize your treatment options. All that, what these data show is that on a population-wide basis, right, that calcium score, and if you have a 0 calcium, it's the single best predictor of surviving. But that's on a population-wide basis. You have to look at individualized risk assessment to individualized treatment.
That's a wonderful phrase to end with. Yeah. So welcome to all the new fellows. Unfortunately, we have to finish some other questions, but you guys have some lectures coming. So thank you very much.
Thank you. And I wanted again thank you, Leandro, and the faculty here for the opportunity.